Macrocytic anemia means the cell size is high. How do you answer what's the most likely diagnosis from the etiology, presentation? What are the unique diagnostic tests? A 73-year-old man is in the office with progressive fatigue. That happens over the last several months. He's short of breath when he walks up one flight of stairs. That's nonspecific. Any form of anemia could do that. Which one's associated with drinking a lot? Drinks 4 vodka martinis a day. And he feels numb and tingling and has decreased sensation in his feet. Well, this is a person who's got anemia, low hematocrit. Normal hematocrit in a man should be around 40 to 45, should be around 40 to 45. And his MCV is clearly elevated as a macrocytic anemia. Now, what do you do next? Well, the next thing to do in this patient is a smear. You see, because the smear can tell you right away that the first thing is there hypersegmentation. You see, folate will not give you neurological problems, but both B12 and folate are identical hematologically. First of all, Schilling's test is never first. Not first ever, and rarely if ever done. Schilling's test to see if the B12 deficiency is from pernicious anemia, and is almost archaeologic. We're pretty close to saying it's pretty much never the right answer. Methylmalonic acid confirms you have B12 deficiency if the B12 level is equivocal. But when you have macrocytic anemia, the first thing to say is, hey, is this megaloblastic? And the big issue is alcohol can do everything that B12 can do, except alcohol won't cause megaloblastosis. Alcohol can cause a macrocytosis, big cells. Alcohol can cause peripheral neuropathy. Alcohol can cause dementia, but alcohol can't cause hypersegmented neutrophils. Megaloblastic anemia, by definition, is hypersegmented neutrophils. A normal neutrophil should have on average 3.5 lobes. If your average is above 4, it's hypersegmented. It's megaloblastic. Now, there are a lot of things that can raise the MCV, make big cells, but only B12 and folate, and some of the antimetabolite chemotherapies like 6-mercaptopurine, azathioprine, immunosuppressive agents can cause hypersegmentation. Basically, and they do it by also inhibiting folate too inside the cell. So only B12 and folate can cause hypersegmented neutrophils. And also you cannot distinguish them based on a smear. Vitamin B12 deficiency is caused by pernicious anemia. You start making autoantibodies, typical in older patients. You become allergic to your own gastric lining and start getting rid of your own parietal cells. The same way some people get monoclonal gammopathy of unknown significance, extra autoantibodies. Why is that happening? Because it does. You get vitiligo, Hashimoto's, autoantibodies. So you can with pernicious anemia as well. Pancreatic insufficiency is the one that people get wrong the most because most people don't know that you need pancreatic enzymes to absorb B12. They don't know that you need pancreatic enzymes to release the B12 from the R protein in the saliva so it can bind with intrinsic factor. Without pancreatic enzymes, you can't get your B12 attached to intrinsic factor. Dietary deficiency is very rare. It happens in strict vegans, and it has to take at least several years to get down there. And if you're a person who actually drinks milk or has yogurt, you'll be fine. It's fine in yogurt. You have to be a real vegetarian person who doesn't even drink the milk. Crohn's disease and anything else that damages the terminal ileum will block B12 absorption. And a blind loop syndrome is an older problem because that's back from when we used to do gastrectomies and gastric bypass for weight loss and mostly ulcer surgery and left these blind loops about which could overgrow. Oh, our scared little tapeworm, Diphyllobothrium latum, also used to eat up the B12 before it got into you. Celiac disease causes B12, folate, and iron deficiency. The B12 deficiency is strictly because it is one of the causes of damaging the terminal ileum. And in this sense, you can also say Whipple's disease, not Whipple's procedure, but Whipple's disease could do it as well. And so can celiac disease. Celiac damages the terminal ileum. Whipple's diagnosed damages the terminal ileum. And tropical sprue damages the terminal ileum. Folate deficiency can happen from anybody who's deficient in it by diet. And that's much easier to get than B12 deficiency because B12 stores for a long time. Folate does not store. Now, there's a little tested fact here, right? Goat's milk has no folate. Wow. don't drink those goat milk too much. And if you wonder about it, it's not just because the goats are small. It's because cow milk has the B12. Isn't that interesting? And the folate, too. So psoriasis, skin loss, cell turnover, that's why all patients with chronic hemolysis need folic acid deficiency. Cell production, cell production, cell production, cell production. Spherocytosis needs it. Cell production, cell production. Sickle cell, sickle cell, sickle cell. Cell production, cell production, cell production. And phenytoin does it also because it causes a loss of folate. Sulfa interferes with the metabolism of folate. Phenytoin causes a loss of folate. Methotrexate is a folate antagonist used in rheumatoid arthritis and also suggests folic acid deficiency. Because of increased cell production, this is why pregnant ladies are so vulnerable. The cells grow faster, and Mr. Baby uses up all the folate. Alcohol causes a macrocytosis and neurological problem, but it will not give hypersegmented neutrophils. B12 deficiency can give any neurological problem. Anything. Not just posterior column damage, not just loss of position of the vibration sense, not just posterior column, not just subacute combined degeneration of the cord, not just dementia, not just neurological things in the central, but the peripheral neuropathy is the most common. And that's because peripheral nerves are simply more vulnerable to everything. So peripheral neuropathy is the most common. Dementia is the least common. And posterior column damage to position and vibratory sense, or the subacute combined degeneration of the cord, is simply classic. It's this and syphilis. Look for ataxia as you damage the neurological reflex arcs. B12 can give either neurological problems alone, hematological problems alone, or both. You don't have to have both together. You just don't. Peripheral is the most common, but anything can occur. The labs that are common to both B12 and folate, they're both megaloblastic. They both cause hypersegmented neutrophils with an average number of lobes above 4. They both increase LDH and indirect bilirubin. They both decrease the reticulocyte count. And the LDH and bilirubin is very hard for people to understand, but I understand that. That's because you don't understand that the cells are made and then they're destroyed just as they're leaving the marrow. So you make the cells, but as they're destroyed, boom, they create LDH loss. Boom, they release indirect bilirubin. But since the cells are destroyed right after they're made, the reticulocyte count never goes up. That's why the bone marrow's hypercellular, yet there's no cells in the peripheral blood. Whee! Macroovalocytes means big cells that are in oval shapes. That's on a smear. Macroovalocytes and characteristic of B12 and folate deficiency. Now, both B12 and folate, and this is one of these tested points, that which of them gives an increased homocysteine. They both give homocysteine, but only B12 gives an increase in methylmalonic acid. That's a colossally important point. You got to know it, that only B12 gives an increase in the methylmalonic acid. The top two cells are pictures of hypersegmented neutrophils. That's more lobes than there should be. That's 5 lobes. And the one on the left and the top. That's 5, and the one on the left and the top. The one at 9 o'clock is 5 lobes. They both do, the one on the left and at the top. And that is why these two disorders are identical hematologically. You could not tell which one you have. We have a 73-year-old woman with decreased position and vibratory sensation at the lower extremities and a macrocytic anemia. Ooh, she's also got hypersegmented neutrophils. That means it's megaloblastic. The B12 level is decreased, but it's near the borderline of normal. What are you going to do next? You had a story like B12 and a normal B12 level. So you should do the methylmalonic acid level. That's what it's for. Now, intrinsic factor and parietal cell antibodies are not to tell you you have B12 deficiency. They are to tell you why. Why? Am I allergic to my own parietal cells? Am I allergic to my own intrinsic factor? Pernicious anemia is an autoimmune disease. It's like Hashimoto's thyroiditis, vitiligo. It is like a person who's having primary biliary cirrhosis. I'm allergic to myself. Schilling's test is rarely done, tells you why it is that you have B12 deficiency. If the intrinsic factor and parietal cell antibodies are normal, you go, gee, it's not pernicious anemia. Why is it? Maybe I'll get a Schilling's. And it's totally premature to do it now. There's no point in checking folate because folate simply doesn't give neurological problems, period. No neuro with folate. Folate, no neuro, period. And homocysteine just doesn't add anything. It can be up, but so what? Bottom line, what are the high-yield tested facts about macrocytic anemia? And the answer is Schilling's test is never the right answer. Period. Thank you. Pernicious anemia is confirmed with anti-intrinsic factor and parietal cell antibodies. And red cells are destroyed as they leave the marrow, so the reticulocyte count is low, but the B12 level is still low, and you have also a increased LDH and an increased indirect bilirubin. What are the other tested facts about macrocytic anemia? B12 and folate deficiency can cause pancytopenia too. Did you know that? All three cell lines could be down. You need pancreatic enzymes to absorb B12. You need it to free it from the R protein. And the neurological problems will improve as long as they're minor, like peripheral neuropathy, a little numbness and tingling, and they're not there for years. You can't take someone who's been demented for 2 years in a nursing home and expect that to reverse by giving B12. Pancreatic enzymes are more indispensable than you know. I know this will sound repetitious to some of you, but it doesn't matter because the major issue is this is the most common wrong answer. When people think, oh, I don't need the pancreas for B12 absorption, well, yeah, you do. You should be so lucky to get a treatment question. Gee, what do you do with B12? How about give B12? Good idea. Replace the B12 on the folate. But what's the tested question for you? Folate replacement is going to correct the hematological problem of B12, but not the neurological problem. That's the tested point. If you miss the diagnosis of B12 and you replace the folate, the red cell count's going to get better and the person's going to get demented. That means if you're a person who with B12, and remember you can present just with hematologic problems at first, and you get folate because it's misdiagnosed, you will fix the hematologic problem and they'll show up demented 6 months later. So which of the following is the most common complication of B12 and folate replacement? You replace the B12 or folate and you develop hypokalemia. Hypokalemia? Really? Why? Because it's the only thing where you can package up so much potassium that you actually use it all up. No kidding. You don't get seizures with B12 and folate replacement. And it's not that you get hemolysis at all. The cells are produced rapidly, not destroyed. They're produced rapidly. Hyperkalemia happens from cell breakdown. High potassium is from massive breakdown. Rhabdomyolysis, hemolysis, tumor lysis. This is the exact opposite. This is cell production. This is exactly the opposite. Diarrhea does cause hypokalemia, but this has nothing to do with causing diarrhea. As a matter of fact, B12 and folate deficiency can sometimes cause diarrhea. If anything, it should resolve. It won't cause diarrhea. It can help diarrhea resolve.